computer. The first 2 years I had guests for this topic, and it just didn't feel right. Like I love the pharmacy guests, but it was the person who did it last year just went into a realm that just felt too much. And they were like our fourth guest, and I was just like, I'm gonna cut that one, and I'm gonna do it and try to whittle it down to what I would want covered. So if I stumble through this, I'm not as familiar with this slide deck. It's pretty new because I just was revising it through the week. So hopefully it goes well though. So these are the objectives. We're going to talk about pain, discuss how it's measured a little bit, like that's one slide, not really very much, but describe the types of pain. Pain is talked about in a couple different ways, but two major types of pain, nociceptive and neuropathic. And you've heard the term neuropathic pain before. We've talked about that like with diabetes. Identify common medication used in different types, levels of pain, mild, moderate, and severe. We're going to discuss the basic pharmacology of analgesics commonly used for dental pain, including the mechanism of action, effects, and cautions, sort of the things we always sort of talk about. We want to know the maximum daily dose of acetaminophen, 4 grams, and ibuprofen, 3.2 grams. You can like highlight that right now. Those will be questions on the exam. Like you will be tested on those numbers, 4 and 3.2. So you can just highlight that right out the gate. Define the 4 stages of surgical anesthesia. We talked just a tiny bit about that. Briefly discuss ASA, classifications, discuss basic pharmacology for sedative anesthetics, most commonly used for dental procedures, MOA, side effects, cautions, and then opioid overdose and Narcan or naloxone or something. I think I'm mispronouncing it. These are the drugs for this unit, but we don't actually cover local anesthetics at all. So I think I thought I might cover it, but then I didn't because we don't really have time. And then you get it all summer. So I'm like, I get it all summer. So I sort of feel like I should have it in this class a little bit, at least an introduction, but I haven't found a spot for it yet. And you do get it plenty in the summer. They do an excellent job covering all the stuff you need to know in summer. So for pain, a definition of pain, I have a couple different definitions here. Pain is an unpleasant sensory, so the feeling of pain, like actually feeling the poke or whatever, cut, whatever it is, and then an emotional experience, so kind of like the psychological response to the pain, associated with either an actual injury or potential tissue damage, or described in terms of such damage. That ending kind of sounds a little funny, but it's basically those two pieces, your sensory and your emotional components to the tissue damage or perceived damage. In other words, the body is made urgently aware of the presence of tissue damage. Usually, that's the main thing. Something is damaged and the body's being notified. The purpose of it is to protect you. So if you hurt yourself, you don't want to keep, a lot of this makes sense. You don't want to keep using it if something's gone wrong, or if you're in a crisis situation and you need, to stop bleeding or something. So it's to alert you that something's wrong. Reduce the use so you heal, so you stay off of something. If you injured your knee or you injured some other body part, you want to give it time to heal, prevent more injury, and then make you aware if something's wrong. You can think of like illnesses like cancers and things like that. A lot of times you start to get pain, but sometimes it's in a later stage, and sometimes pain comes late. So these are just a couple figures of the pain pathway. This one is showing the injury, like a needle stick, and then there's chemicals that are released, all these different chemicals. Sometimes we just talk about them and say prostaglandins. It's sort of an easy common word to grab for. So that's why that one is sort of highlighted there. But chemicals are released and they're basically just doing the same thing. You can think of it in a similar ways when we talk about neurotransmitters and how they travel through the body as a communication, like messengers. Then prostaglandins do the same thing. They travel this message to the brain interprets it, says, oh, pain, react, and then that goes back to the hand, so the hand reacts and, you know, pulls your hand away from a hot stove or whatever it is. And it happens obviously practically instantaneously. I mean, it happens so fast, you just don't think about the fact that a process had to happen. And this just shows it again. It's just showing how it goes from the source of the pain through peripheral nerves to the central nervous system to the brain, and then it'll travel back to get the body part to react, to do something different. So two parts of pain, there's the sensory or the perception. That's the actual pain stimulus, that's the actual injury, and then it originates from the peripheral nervous system. So arms and legs and shoulders and just everything off of the central nervous system, everything off of the spine and the brain is the peripheral. And then there's the reaction to the pain. So this is that, again, the more emotional. Yeah. It is. What did I say? Did I say? Oh, yes. No, the central is your brain and spinal cord. Sorry if I misspoke. Sorry. Oh, central nervous system, it's your brain and your spinal cord. And then the peripheral nervous system comes off of that. So I think I said it backwards the first. So with the reaction to pain, that is that emotional response. And this is more important than the actual pain stimulus in controlling pain. And it's really interesting. We don't talk very much about it, but there is a whole interesting world. I delved into it a little bit when I was writing a paper on geriatric care and older people and dealing with chronic pain, and how things like loneliness and all of these emotional states can affect pain. And also there's really interesting literature with hospice too, like hospice care or end of life care. So there's different people will have different levels of pain, or they'll experience it or respond emotionally to it depending on so many things. So we talk about pain tolerance. Some people have a higher or a lower pain tolerance. And that depends on so many factors. And then this reaction, this emotional reaction, originates from the central nervous system, so the brain. So nociceptive pain, nociceptive is pain that arrives from a stimulus, so from the actual injury, injury to the tissue, bones, joints, muscles, connective tissue, anything outside the central nervous system. It has fast onset, happens immediately with the injury. And we revisit this on another slide again, but within that, there's somatic pain and visceral pain. And you can think of somatic pain as sort of a sharp or localized injury. And then you can think of visceral. So I heard one doctor describe it as like just the organs, like in general, you can think of visceral as like collectively all your organs. So it might be something happening more like internal. And so there's different types of pains then that would be related to that. There would be like dull, poorly localized, like throbbing, radiating, referred pain. There's all kinds of different ways and different things that could happen. So somatic pain, you think of more as like sort of a blunt injury that would happen, like a cut or something that would happen like that. And then visceral might have all these kind of complex things, and you can think about it happening within the organs. For neuropathic pain, we usually line up neuropathic pain with like disease states, and it's a lot harder to treat that. So you don't just pop an ibuprofen for neuropathic pain. It's usually treated differently. It's pain from nervous system damage, injury, or disease, not a response to a stimuli. So not a response from a cut or a poke or something. Examples from diabetes is the big one, MS, stroke, phantom limb pain. Someone has amputation. And then, of course, there's also acute and chronic pain. Acute happens short-lived, intense. Chronic is usually like not as intense, but it goes on and on and on. That lasts longer. Well, the terms acute and chronic can be used for so many different things, But I think in general, you can take the timing of pain probably in both, but neuropathic would be more chronic, and nociceptive would probably be more acute. Because so I think they probably line up better that way, but there might be exceptions to that. And then as far as drug treatment, so nociceptive pain, since it's kind of injuries, it's probably more acute. It's probably not going to be something that's going to last for a long time. You can treat that effectively with, and based on the neural pathways that are affected, you can treat nociceptive pain with NSAIDs and acetaminophen and aspirin and opioids and things like that. Whereas neuropathic pain, you might remember from the previous chapters, anti-seizure, antidepressant medications, chronic fatigue and things like that, or fibromyalgia. That's the one I was thinking of. Things, different pains like that they're not affected by taking an ibuprofen. So a little bit more on that same topic here, just maybe written a little bit differently. So nociceptors are all the pain receptors. And there's a good little video here I'll play in just a second. I think I'll pause it and pull it up. But nociceptors are located on the ends of the nerves within the peripheral body tissue, and they're stimulated by noxious stimuli or some kind of an injury. Normal pain is a response to body injury, like we said. So somatic pain, again, localized, sharp pain, visceral pain, internal organs, dull. A heart attack pain, the pain from a heart attack is a visceral pain. So that's not a somatic pain, that's a visceral pain. Pain, and this is sort of a repeat of what we already said, pain prevents a person from using injured parts to avoid further injury. When we use local anesthetic, we're blocking the nociceptors. So when we inject the local anesthetic, chemically, that's what's happening, is the local anesthetic is blocking the nociceptors. So when you stab somebody's gingiva, when you're scraping down on the bottom of an 8mm pocket, they don't feel it because those nociceptors at the ends of the nerves are blocked. So pain is provoked when a variety of substances are released or injected into the tissue after trauma, surgery, or inflammation. And those chemicals, so we already kind of talked about this, those chemicals, there's various different ones, histamines, prostaglandins, you hear that word a lot, leukotrienes, and there's other ones. They're just chemicals that your body releases when you get injured. Okay. So this slide just kind of shows this pain threshold. So there's lowered pain thresholds are some things that will contribute to it are anxiety, if somebody is not sleeping well and over the course of like many nights of not sleeping well. So if they're tired, if they're angry, if they're fearful, if they're starting to feel some signs of depression or some depressive feelings, or they're just kind of constantly sort of just uncomfortable and in pain, or if they're isolated and lonely, all of those things will lower somebody's pain threshold. And then what raises it is if somebody is well adjusted, well rested, sleeping well. Diversion, that might be like distraction, perhaps. I should have looked that up, but I think that makes sense. If somebody is, you can literally distract people from their pain. Like that's a technique. And you do that with kids, like you try and distract them if they fell and skin their knee, like, oh, something else. And so diversion, empathy, and then if somebody's empathic, I suppose, or if somebody's showing empathy to them, that really was, now that I'm saying it out loud, I do remember reading about that. People who show that they care, and that will help people deal better with pain. That was in some of the studies of the older people. And then, of course, if you interject something like a chemical, a local anesthetic, an analgesic, an anti-inflammatory, or antidepressant agents or anti-anxiety agents, all those things will raise your pain threshold. You'll be able to tolerate the pain better. This slide is sort of a repeat slide. Neuropathic pain, all of these different things can contribute to neuropathic pain. Diabetes is a big one we always talk about, but the different herpes viruses, fibromyalgia, cancer, amputated limbs, spinal cord injury, B12 deficiency, that's kind of interesting. Trigeminal neuralgia, infectious diseases, HIV and Lyme disease. These are all different diseases that can, or deficiencies that can contribute to neuropathic pain. Difficult to treat, and so that there usually is maybe a mix of treatment, mix of medications used. And so, you know, a lot of times when we measure pain, it's very subjective and it's hard to like pinpoint it like super, you know, super specifically. But so then they'll try and get a feel for it. So these are some kind of universal scales for pain, like, you know, how are you feeling? I have always had the toughest time. Has anyone had experience with this and being like, I don't know, am I a 6 or a 4 or 9? I don't know. What does it feel like? Is it much worse? Like, I feel pretty bad right now. I mean, it's just, I find it kind of difficult. I don't know. And I'm thinking of like pregnancies, like when I was in the hospital and they ask you that, like, how's your pain right now? It's like, I don't know. It's hard to say. But that's what, you know, that's what we got. And somebody's, you know, somebody's broken leg might be a 4 to somebody and a 9 to somebody else. So, I mean, it really is very subjective. Okay, so there is this slide was originally at the end after we talked about opioids and different things. But the best pain management for somebody, especially with chronic pain, if it's something acute and they just need it for a week or something like that, that's different. But if somebody is in chronic pain, the best pain management is to use multiple things so that somebody doesn't have to rely on massive doses of opioids or something like that. So there's all these different things. A sample, so for like low back treatment, there's physical rehabilitation. Medication is obviously a large part of it. TENS, I don't know if any of you have ever tried the TENS, a little electric shock. They have it and put it in different parts of your body, but it's like it stimulates something and it's supposed to help with all kinds of stuff. And pain obviously is one of them. And then psychology intervention, so talk therapy, cognitive behavioral therapy can really help with chronic pain. And then injections, anti-inflammatory steroid injections, and acupuncture is also another really big one. So all of these things together, they can result in like lower doses of opioids is the big one, and then less adverse reactions. If someone has to take a lot of opioids, there's a lot of GI issues and constipation, things that you don't want. So. Okay, and so when we're going over all these medications, just think about it in terms of you might get confused if you've already looked at the study guide, because I didn't take it off of the study guide, but this PowerPoint used the WHO, like World Health Organization, WHO something for pain, and I didn't like it. It was so confusing to me. And every year for the 2 years before, students would get confused on, I'd ask questions based on the old material and students would get confused. I was like, it's taking it out. So it's just, if you think about it, the way to easily divide it, if somebody's experiencing mild pain, they're going to be fine with probably an over-the-counter ibuprofen, Tylenol, aspirin, whatever. Like that's just kind of, at this point, we all probably can get that, right? And then if it's moderate pain, they may need prescription strength. So maybe they need a doctor to tell them what's the max dose they can have, or maybe they'll take like a Natodolac or a naproxen, something that lasts longer, something that's maybe a prescription dose. And then maybe they'll also have them double up and do acetaminophen and ibuprofen. They work on different receptors, and so they've shown it to be just as much pain analgesic effect as an opioid. So if they have moderate pain, they're probably going to take higher doses of those and maybe together. And then if they have severe pain, then we go into the opioids, and then those opioids might be mixed with an acetaminophen or an ibuprofen. So that's basically how you can think of mild, moderate, severe. I feel like that's, I know you guys don't know what the WHO look like, but trust me, that's simpler. Yeah. APAP is acetaminophen. Yeah. And I don't remember exactly why APAP, but if you look at, I think the chemical name, you can see it, but it's short for acetaminophen or Tylenol. Yeah. Okay, so I'm gonna just pause for a second. I want to pull up this video. And this video talks a little bit about what we've already seen, but then it also kind of gives a little information from what we're about to look at. If I can find it. Is this it? Where's the... Where's the volume? Oh, maybe up here.
How do you know the sand is there? You obviously can't see it, but if you're a normal, healthy human, you can feel it. That sensation of extreme discomfort, also known as pain. Now, pain makes you do something. In this case, rinse your eyes until the sand is gone. And how do you know the sand is gone? Exactly, because there's no more pain. There are people who don't feel pain. Now, that might sound cool, but it's not. If you can't feel pain, you could get hurt or even hurt yourself and never know it. Pain is your body's early warning system. It protects you from the world around you and from yourself. As we grow, we install pain detectors in most areas of our body. These detectors are specialized nerve cells called nociceptors that stretch from your spinal cord to your skin, your muscles, your joints, your teeth, and some of your internal organs. Just like all nerve cells, they conduct electrical signals, sending information from wherever they're located back to your brain. But unlike other nerve cells, nociceptors only fire if something happens that could cause or is causing damage. So gently touch the tip of the needle. You'll feel the metal, and those are your regular nerve cells, but you won't feel any pain. Now, the harder you push against the needle, the closer you get to the nociceptor threshold. Push hard enough, and you'll cross that threshold, and the nociceptors fire, telling your body to stop doing whatever you're doing. But the pain threshold isn't set in stone. Certain chemicals can tune nociceptors, lowering their threshold for pain. And when cells are damaged, they and other nearby cells start producing these tuning chemicals like crazy, lowering the nociceptor's threshold to the point where just touch can cause pain. And this is where over-the-counter painkillers come in. Aspirin and ibuprofen block production of one class of these tuning chemicals called prostaglandins. Let's take a look at how they do that. When cells are damaged, they release a chemical called arachidonic acid. Now, two enzymes called COX-1 and COX-2 convert this arachidonic acid into prostaglandin H2, which is then converted into a bunch of other chemicals that do a bunch of things, including raise your body temperature, cause inflammation, and lower the pain threshold. Now, all enzymes have an active site. That's the place in the enzyme where the reaction happens. The active sites of COX-1 and COX-2 hit arachidonic acid very potently. As you can see, there's no room to spare. Now, it's in this active site that aspirin and ibuprofen do their work. So they work differently. Aspirin acts like a spine from a porcupine. It enters the active site and then breaks off, leaving half of itself in there, totally blocking that channel and making it impossible for the arachidonic acid to fit. This permanently deactivates COX-1 and COX-2. Ibuprofen, on the other hand, enters the active site but doesn't break apart or change the enzyme. COX-1 and COX-2 are free to spit it out again, but for the time that ibuprofen is in there, the enzyme can't bind arachidonic acid and can't do its normal chemistry. But how do aspirin and ibuprofen know where the pain is? Well, they don't. Once the drugs are in your bloodstream, they are carried throughout your body, and they go to painful areas just the same as normal ones. So that's how aspirin and ibuprofen work. But there are other dimensions to pain. Neuropathic pain, for example, is pain caused by damage to the nervous system itself. There doesn't need to be any sort of outside stimulus. And scientists are discovering that the brain controls how we respond to pain signals. For example, how much pain you feel can depend on whether you're paying attention to the pain or even your mood. So pain is an area of active research. If we can understand it better, maybe we can help people manage it better.
So, that's in the Moodle page. If you want to watch it again, that's in the, in this week's Moodle. It's like third down. But I liked it because it talked about the COX-1 and COX-2. And, that comes up, in a little bit here when we go over ibuprofen. I didn't really include aspirin very much. It's in, the text, but we kind of talked about it earlier with blood thinning and the antiplatelet properties, and it's been just kind of mentioned throughout. And so I have it here as sort of, oh, here's a couple other videos. This one, we won't play them, but this one it's a doctor kind of talking about chronic pain, and he mentions a few good things to help kind of describe things in a different way. Stuff that we've already kind of mentioned already, but I thought it was a good video. And then this is a really short, super short video that just says what we've already said like 3 times about how pain travels, the message travels to the brain. And so that's just a couple more for references. But so the common non-opioid pain medications, basically the 3 categories would be the acetaminophen, which can be also combined with opioids for more severe pain. Then NSAIDs, the whole category of NSAIDs, the non-steroidal anti-inflammatory drugs, and there's a number of medications there. And in general, all of these can cause a reduction in opioids. So I don't know why it's just under the NSAIDs. That's kind of seems silly to me now, but anyways. And then the salicylates, which includes aspirin, and we don't really cover those. But just so you know, that's a category that some people choose to take. Not as many people choose to take aspirin when they're in pain, but it used to be more popular in the olden days. So acetaminophen, we'll talk about first. So the mechanism of action for acetaminophen is not super known. So they don't really know exactly what happens when the chemistry cascade starts taking place. It's thought to produce analgesia analgesia by elevating the pain threshold. So it just makes you able to tolerate pain better. It just elevates the pain threshold. So it's kind of what they've come up with. The antipyretic, which is that anti-fever, you take Tylenol, you give kids Tylenol when they have a fever. Antipyretic effects may be a result of an inhibition of endogenous pyrogens. So endogenous meaning they're in your body doing their thing, on the heat regulating center of the brain by blocking the formation and the release of prostaglandins in the central nervous system. So they're blocking some body mechanism that would normally cause a fever. So you're probably not going to get a question on the mechanism of action of acetaminophen, other than, unless, the answer might be like, overall it's unknown. They know it does something, but they don't really know what. But those are the best guesses, are that it raises the pain threshold and that it's blocking some kind of a mechanism when it comes to fever. Of course, it's effective for things like arthritis and headaches and acute pain and fever and things like that. So, but the step that I really want you to know is on this slide. That's the yellow star. So side effects for acetaminophen are GI effects. There is a very strong liver toxicity warning when you consume acetaminophen. You want to consider, and you want to talk to your patient about considering other drugs that have acetaminophen in it, or other drugs that could affect the liver, or if somebody is a heavy drinker, anything that taxes the liver, you want your patient to understand. Or if they're taking, like, I'm taking Tylenol plus I'm taking some cold medicine that has acetaminophen in it and they don't know it has it. So you do just to be cautious, because there is a not to exceed daily dose, NTE, not to exceed, of 4 grams a day. generally speaking, people will take about 6 to 1,000 milligrams, 600 to 1,000 milligrams every 4 to 6 hours, is a kind of typical dose, I guess. Liver dysfunction and heavy alcohol use is cautioned. Less than 3 drinks a day, which still seems kind of excessive. And then that's just FYI a pediatric dose. I don't think you get tested on pediatric doses. That's just kind of there for FYI. But the big take home things, the not to exceed, think about the liver. When you think about acetaminophen, your brain should go to the liver. Think about, and you just need to connect those because it's different from ibuprofen, and caution with alcohol. For NSAIDs, the mechanism of action, this is a little bit more specific, and I actually think that you might have to make some verbal notes because I feel like there may be questions on the exam and I might not have emphasized it as well as I'm thinking I should have in this PowerPoint with the COX, COX-1 and COX-2. So just make sure you write this down. But NSAIDs, so the mechanism of action, NSAIDs inhibit the enzyme cyclooxygenase, so resulting in a reduction in the formation of prostaglandins. And the precursor, and you don't need to know these words so much, but you remember from the video, the arachidonic acid. So basically, when you take an NSAID, like the video said, it pops into those COX-1 and COX-2. So there's COX-1, COX-2. Pops in there and it prevents that cascade of effects from going on so you don't feel the pain, and it's anti-inflammatory. And then as you'll see here, oh, this does it pretty good. Okay, just write it on this slide. So it doesn't, there are some medications, and we don't go into those details of those medications, which maybe I should, but there are some medications that are selective. They're selective for COX-2, and they're selective for COX-2 because you can see that COX-2 does the things that we want to address, right? Pain, inflammation, fever. So we really want to block COX-2 receptors, but COX-1, renal homeostasis, gastric mucosal protection, platelet function, you don't really want to screw with that. You don't really want to mess up their renal homeostasis, but a lot of the NSAIDs will block the COX-1 receptor. So those are the side effects. Those are what you're getting that you don't want. The COX-1 gives you pretty much what you don't want. COX-2 gives you what you do want. So when you block those receptors, you're likely going to get some side effects that are not desirable from the blocking COX-1, but you're getting the pain relief and inflammation that you do want from blocking COX-2. Yeah.
Like Tylenol blocks both, but there are some medications that can block.
Yes, yes. So like so this is the ibuprofen world. So yeah, that's okay. So ibuprofen, but there are like, so is it Celebrex? So it's a C. It's Cella something. That I think is a COX-2, selective COX-2 inhibitor. But things like ibuprofen, most of the NSAIDs are not selective, and they will block. And that's why you get GI issues. That's why you get all these things that we don't want. I don't know. That's a great pharmacy question. It probably has something. I mean, obviously it's got to have some chemistry reason. And I know that there might also be some give and take with some other side effects, and it could, and I don't want to say anything that I don't really know, but I know that there are, like, if we go on to, we'll go on to side effects here in a second, and that might reveal a possible answer, but I think we'd have to ask pharmacy.
And that was the Celexa.
Yes, it's not Celexa, that's Cycle, that's Celexa's, Celebrex is the NSAID. Okay, so ibuprofen, Motrin, a typical dose there, 200 to 400 milligrams every 4 to 6 hours. And then not to exceed 3.2 grams. So we're talking grams a day. And then that's just FYI, the pediatric dose. So those not to exceed doses are, of course, like I already said, important to note. So for NSAIDs, so this isn't talking about Tylenol, this is just talking about NSAIDs and all the different ones that are included under that umbrella category of NSAIDs. There's quite a few adverse effects. So directly attacks the stomach lining. So there's the GI side effects, increases risks of ulcers, perforation, and GI bleeds. NSAIDs are generally contraindicated in pregnancy. However, just from a personal experience, in my second trimester, I was given one and I was like, aren't I not supposed to take this? But it was a high risk situation. And so I think there are some categories of where they might give it, but in general, if you have a lady that's pregnant, you should be like, well, something hurts. Can you just give me like a ibuprofen? No, I can't. So in general, no, you don't give them pregnancy. It's contraindicated. Increases blood pressure, increased risk of thrombotic event, stroke, increased risk of heart attack and stroke. Is it Vioxx? Is that the one? There is a compelling documentary about Vioxx that was out on the market for a long time and had incredible high risk of heart attack. They pulled it off the market. They got sued up the wazoo, but it was an NSAID, and I don't remember the details, but it was an NSAID, and so that's why I wonder, going back to Lacey's question about like, why don't they just make them all COX-2 selective? And I don't know for sure, but I wonder if it has to do with if you do certain, chemistry is crazy, and if you do certain things, you tolerate this risk, but that risk becomes too great. It's a far better question for pharmacy. I don't know, but that makes me think that it might have something to do with that. There's a lot of notes here on the side that you can read through. They just give a little bit more detail of these side effects. And so I won't read them, but I encourage you just to make sure you go through and read the notes. The other important thing about NSAIDs that you really want to know, NSAIDs think kidneys. Acetaminophen, you're going to think what? Liver. NSAIDs, you're going to think kidneys. So sodium and fluid retention, electrolyte abnormalities, there's a risk for acute kidney failure. There is this inhibition of platelet aggregation. So there's this thinning of the blood side effect and increased bleeding side effect. Now, different from aspirin, aspirin, like it showed in the video, it's like stays there. It's like, I'm not going anywhere. And it's permanent. But so NSAID, that's why people take low dose aspirin, because it like permanently like thins their blood, but as long as those cells are alive. But with NSAIDs, it's temporary. So it thins the blood, but it's just temporary. So those are some differences between aspirin and an NSAID for platelet aggregation. So these are just whole bunch of medications that are considered NSAIDs. Notice aspirin is under there. I think it's because they just work so similarly. Naproxen, I want to draw your attention to this drug here, because if you are ever asked a question on an exam that asked about, my patient doesn't want to take a drug every 4 hours, what would be a better option for them? What might you consider then? And why would you, what makes you think naproxen would be better than like a Motrin or something? And the overall, the length of time it's in the system. So they might only have to take, I know like when my husband was taking it after he got in a car accident, and he just took one every 12 hours. So it was like a 12-hour pill, like one naproxen every 12 hours. So you just don't have to take it as often. So if that's a concern for a patient, they just don't want to be taking pills every 4 hours, you can make a recommendation for something that's dosed differently. We used to give a Totalac in my office. We used to give everybody in a Totalac right before SRP. I'd offer it to them, like just everybody, here, have a Totalac. I didn't think much about it. The doctor just told me to do it, so I did it. But it's like I think we gave him 200 milligrams of a Totalac, so pretty, like a relatively low end. But we're like, we just preload you so that after after the procedure, if you have any inflammation or discomfort, you already have it on board, and most people took it and sometimes they didn't. And if there was a contraindication, we didn't give it. So another thing that I want you to pay attention to is the ceiling effect here. So of course, it's super unhealthy for the liver and the kidneys to take too much of these medications. Like that's just like really, really bad for those. The body just can't process that much. And it's very toxic. You go into a toxic level, but you also don't get any more pain benefit, any more analgesic benefit, should I say. So you've kind of hit a ceiling effect for the maximum dose. Like they don't, I think it's something like, I feel like it's something like 10 grams or something is like okay, you're headed to the hospital. Like, it's not like someone takes 4.5 grams and they're going to be in the hospital. It's something like, it's higher than that. It's like 10 grams or something for acetaminophen. But once you've hit that ceiling dose, that 4 grams, you're not going to really get any more benefit from taking any more of the medication. You're just going to be hard on your liver or hard on your kidneys if it's ibuprofen. So I want you to remember that term, ceiling effect. Okay, so now we're gonna, how much time? I got a few more minutes. Okay, so now we're gonna go through opioids.
Are you gonna put more emphasis?
If the question asks about that note, do not exceed, it'll be in grams. So that's why I just want you to remember 4 grams, 3.2 grams, just those numbers and you'll be good. So for opioids, natural or synthetic substances, I put a little thing in the notes here. I like the history of stuff. So opium is the dried juice of the unripe seed capsules in the opium poppy, of the opium poppy plant. And as early as 4000 BC, many cultures had recognized the euphoric effects of the poppy plant. And in the early 1800s, that's when they derived morphine and codeine from opium. So before that, it was like, mostly just opium, but then they got in there in their little chemistry and figured out some different drugs. And now we keep doing that. We keep figuring out different things. Opioids are effective for many types of pain, but not always appropriate. They bind to opioid receptors in the central nervous system. So that's why it affects respiration and things like that, because it's the central nervous system. It inhibits the transmission of nociceptive pain impulses and activate inhibitory pathways that modulate pain. And we'll talk about the receptors specifically here. So there's actually a third receptor, but we're just going to talk about mu and kappa, mostly mu. So the mu receptors, they have a lot to do with the analgesia, so pain relief, euphoria, decreased respiration rate, decreased GI motility, thus constipation, things just aren't moving, sedation, and then physical dependence. So that addiction piece, all of that is off of the mu receptor. So those are some good things, but also some clearly bad things. Kappa receptors have to do with analgesia, so pain control, sedation, which sometimes is desirable, and then lower GI motility, which is never desirable, really. And then here's just another little picture that kind of shows similar things. So with the mu and the kappa receptors, you have the morphine opioid agonist. So it goes in there and it blocks pain and does all the different things. Some medications are an agonist antagonist. It's like a partial agonist, I guess, or that does, and I'm not totally sure what those are used for. We don't really have to know that, and it's not going to be on a test or exam, but they do exist. And then the antagonist, which you should know about because that's the Narcan, the thing that everybody talks about, and you can get it everywhere. It's all over the place. And that is a different type of block that reverses, it kicks out if someone has taken some kind of an opioid, it is very competitive and it kicks it out, but it's short-lived. It has a super short half-life. So it's strong and kicks out the other guy, and that's what saves somebody's life, but then they can go right back in to an overdose state because it has a very short half-life. So that's why they have to give it multiple times sometimes. So common opioid examples with the mu agonist, we have the Oxycontin, we have the oxycodone with the acetaminophen, APA. That's acetaminophen. So Percocet is oxycodone and acetaminophen. Hydrocodone is with acetaminophen. That's your Vicodin or your Norcor. Morphine, codeine, hydromorphone. I don't recognize that one. I've never seen that one prescribed, but I'm sure it is. Then you have your fentanyl. That also is sort of kind of a shorter life, half-life for fentanyl. And then heroin, there's others too. That's not an exhaustive list. Oh, like of that list, which one is the stronger one? I don't, I think it's probably dose related. I don't know really, like which is the strong. I know like anything that's like the oxycodone are very strong, and they liked them because they lasted so much longer. That's why they were so popular, like when they first came out, but there's a myriad of problems that have arisen from those. Yeah. Yes. Yeah, I do think so. I think that's correct. I think, yeah. Like a back surgery and things like that. Yeah. Yeah, I think that's very true. So for the mu receptor, the effects, the agonist effects, this is just a little memory tool thing. You can remember SUV car, and these are all the different things that you'll see the effects that happen from when these drugs are being used. There's sedation, euphoria, vasodilation, decreased blood pressure, constipation, analgesia, respiratory depression, and reduced cough. So, that sometimes there's like codeine in the cough syrup and it reduces cough. So those are some of the effects of the drug. Yes. Yes.
So there are a lot of evidence in a hospital, but it's 10 times more potent than morphine, but it's only a lot of this stuff and this stuff. So you're asking us strength of these different.
Dilaudid. It's
Dilaudid.
funny because when you say the word, all of a sudden I was like, oh,
Yeah.
that does sound familiar. I didn't recognize like the written word, but then when I heard you say it, I'm like,
Yeah.
oh, I do.
I've had it. It's awful.
It's awful.
It's an awful drug.
Oh, but it's up there in like post-surgery type medication. It's severe pain, like high pain. Is that what you were telling me though? Is it high pain?
It's super potent.
Potent. Mm.
And then fentanyl is obviously, yeah, fentanyl is
Mhm.
more dangerous.
Okay. I know, and fentanyl's what's out there all over the place right now. It's scary. Okay, so what about opioid allergies? I found this interesting because a lot of times people will have reactions, and so you get this a lot in the dental office. A dental assistant, you might have heard patients talk about this, like, oh, I'm allergic to this, or what are you going to give me for pain because I'm allergic to that. But there are very few true opioid allergies, like a true allergy. There's more just really kind of bad reactions that are not comfortable. And so like I had Percocet right after I gave birth to my older daughter, and I threw up right away. And then I was like, I think I'm allergic to Percocet. But I think it's because I wasn't feeling great and my stomach was probably empty. So if I'd eaten, maybe I wouldn't have thrown up. So I don't think I'm allergic to it. And then like rash is due to the histamine release. And you could simply, if somebody has a big histamine release and they have a rash, some kind of a reaction that's super uncomfortable, they could just try a different drug. Like doctors do that all the time. They're like, well, that didn't seem to work for you. Let's do something else. Other major risks. So neonatal opioid withdrawal, if the mother had was taking opioids while pregnant, risk of overdose and death. Of course, that's a huge one that everyone's aware of. Excessive sedation, respiratory depression, coma, death. Because it's depressing the CNS, the central nervous system, and especially if it's taken in combination with alcohol, benzodiazepines. Of course, caution with liver or kidney impairment, lower doses and extended dose interval if somebody has of these other comorbidities. So just a little bit about naloxone or Narcan. It competitively binds to the opioid receptor, so it kicks out the whatever the opioid is that's on board, used to reverse toxic effects of opioids. Very short half-life, recommended for all patients on opioids, and people can carry it with them. Signs of opioid overdose include loss of consciousness, slow, shallow breathing, blue skin, fingernails or lips, the death rattle. Does anyone actually know what the death rattle means? I had to look it up. I've heard that term because my mom worked in hospice and she was like, he had the death rattle. I'm like, what's the death rattle? But do you guys know? It's just like when like saliva and everything just is down, it's collecting in the throat and the patient's too weak to cough. And so they're just like, it's gargling. It's the gargling noise, which is very sad. But I was like, okay, I've heard this term my whole life, but what does it actually refer to? But that's what it refers to. Limp body and slow heart rate. Due to loss of consciousness, caretaker friend, family members should be educated on how to use naloxone or Narcan. So here I won't read through it. This I just think, but I do think you should read through this just in case this ever comes around and you or if you some people are choosing to carry one with them just for if they, it's like CPR, right? You come upon a person, then how would you know if they how would you, especially in Portland, it's true, but how would you know if they were opioid overdose or had a heart attack? I don't know. But does it matter? And it's probably not. I don't think it's dangerous, super dangerous. You could just give it to them anyways, I guess. But anyways, I just think it's good to read through this and just kind of be familiar with sort of the process of it, the thought process, so that it's not totally foreign to you if you ever have to be involved with it in some way. So just a few with substance abuse, we're not going to talk at very long length at all because we're running short on time. These are just some terms to be familiar with. Tolerance, obviously over time needing a higher dose because your body builds tolerance to the drug. Hyperalgesia, so it's an increased sensitivity to pain, secondary to increased opioid doses. So when somebody might all of a sudden react more to the pain once they're taking these, especially if there's a rapid opioid escalation or a high dose administered, the next time around the pain may seem like worse. Physical dependence, getting those withdrawal symptoms. No, that's kind of a sign that your body is like needs it. You're starting to get those withdrawals if you're physically dependent. Addiction, it's a pattern of behavior typically characterized by ongoing substance use despite knowing the harmful consequences. And then pseudo addiction, similar to addiction, except the behavior is a reflection of unrelieved pain. I don't know if I understand that so much. Okay, and then some red flag behavior. So these are just some signs, some warning signs: concurrent abuse of alcohol and other illicit drugs, disruption in work, family life, doctor shopping. We see this in the dental office. If you've been a dental assistant for any length of time, you might have witnessed this already, where people come in simply looking for pain meds. And so we kind of call it doctor shopping. Multiple dose increases, injecting oral medications. So that's what part of the huge problem with the OxyContin when it first came out is everyone was chopping it up and snorting it or injecting it. And then stealing drugs and prescription forgery. So those are all pretty red flag behavior. Okay, so sedation. When we talk about sedation in the dental office, usually it's pretty limited. The doctor is usually very limited to what they can do. I mean, unless it's an oral surgeon or they have a license to do more, it's usually some oral medication, like Valium or something like that, and then nitrous oxide. But for an ideal sedation, it's going to be rapid onset. You're going to titrate it easily, meaning you can titrate it to the patient's design, optimum level of what you want for a therapeutic result. Anxiolytic, it's anti-anxiety, there's that word again, analgesic, pain relief, and rapid and complete recovery. Minimal sedation, drug-induced state during which patient responds normally to commands. So that would be like taking a benzo, they're minimally sedated. Moderate administration of drugs for the purpose of sedation, lack of awareness, amnesia, or analgesia. So it's like conscious sedation, they're pretty out. Deep sedation, drug-induced depression of consciousness during which patients cannot be easily aroused, possible to move from moderate to deep sedation without recognition. So that's sort of like a kind of be careful zone. And then general anesthesia, obviously you're in a hospital there, you're on a ventilator, something's breathing for you because you are just like out. Their central nervous system has shut off for a little bit. So induced state of unconsciousness with a partial or complete loss of protective reflexes during maintaining airway. So the stages, the first stage for moderate sedation, we have, there's amnesia and some analgesia. So you're not going to remember anything. It's going to feel like a second. You're just awake, and that, I was awake. You did something. I don't remember anything in between, and then I'm awake again and recovered. So you don't, you lose time, right? And then you have some pain, anti-pain. I don't know how I want to say I'm losing my words, but analgesic relief, pain relief. Excitement and delirium is on the second stage. So those are some not so desirable side effects. Excitement and delirium. Blood pressure can be increased, irregular heart rate, and that's the start of anesthesia. For surgical anesthesia, we have a bit of an increase in the heart rate, blood pressure can drop, pupil dilation, and then required stage for major surgical procedure is the surgical, and then medullary paralysis up here, we don't. But this pretty much 3 is your sweet spot, I think, for surgical. This kind of just reviews the same thing. We have a couple different charts that kind of go over the same material, the same information, just sort of worded slightly different with the pre-med, the induction, the maintenance, and then the recovery of the whole process. There's this one and then this one that's also showing different medications or different techniques that might be used. So local anesthesia, obviously way down here, hypnosis and biofeedback, you're not even using any kind of medicine, you're just using more talk. But you can still get some sedative effects when using even just something like hypnosis, if they've shown that. And then going up the line, these are all patient is still relatively conscious and aware, but there's some overlap here once we get to this stage. So this one back here this is during surgery when the patient would, so I think I got this mixed up. I think I was thinking it was the same as this, but it actually is different information. So sorry, this is actually like the stages of how deep the patient's going to get. And this is during whichever one they're at, usually probably a higher, like a stage 3. This is how they're going to start. It's going to induce the anesthesia. They're going to maintain it throughout the surgery, and then the patient recovers. So these are some stages that you'll see during the anesthesia. So we always talk about our ASA when we talk about our patients in clinic. And one thing that I'm bringing to the special needs course next semester is I want to talk about common ASAs, because there's a few gray areas where, like, is this person a 1 or a 2, or are they a 2 or a 3? So we're going to connect this back to all the different conditions in special needs, but they use this is for the American Society of Anesthesiologists. So this is what they use to determine, risk, I guess. We use it kind of in a totally different way. We know if they're ASA 1, they're healthy, their blood pressure has to be totally normal. 2, they just tiptoe into that slightly above blood pressure and they are an ASA 2. Severe systemic disease. It takes quite a bit to get to a 3. A lot of people are in a 2. It takes quite a bit of severe systemic disease to be a 3. So you'll notice that in clinic. For sedatives, benzodiazepines are very common in the dental office for patients because we just want short acting, something to calm their nerves. So a lot of times we'll see this as an option. And this is just reviewing what benzodiazepines do. They work on the GABA receptors, which have that sedating effect, that calming effect. Nitrous oxide. So I starred this because you may see a question that names other inhalants, so other drugs that are inhalable drugs. But the take-home point is, and this should be easy for anybody who's assisted, because you've never probably used, enflurane in the office on a patient, right? Does that seem like has anyone who's ever assisted used that? No. So this should be an easy point to remember, that the one that's the least potent is nitrous oxide, and really that's the only one you're going to use in an office is nitrous oxide. So that's my take home point. There are other inhalant products out there that are gases, but we're pretty much the weakest one, the least potent is nitrous oxide. No, you don't have to know the concentration. Yeah, it's that on that slide, that's the take home point. And I believe there's a question on the exam, or maybe it's the final. I can't even remember which one it is. This is just, I don't think there's anything on that slide that you need to know. You're going to learn a lot more about nitrous oxide. We never go above the 50% mark. Because we want just some anti-anxiety, maybe there's a little pain, analgesic support, but in our clinic, you might have in practice, you might have seen your doctor go above 50%, but we never do. You're like, I know, mine did too, but we're not supposed to, so don't you do it. But the effects of nitrous oxide, analgesic effect, depersonalization, dizziness, euphoria, sound distortion, hallucinations. And that of course depends on the concentration. How much is the person getting? That's why we kind of titrate it. We check their eyes. We look for kind of the glassy look in their eyes. They kind of have a little bit of a smile on their face and they look relaxed. We don't really want to go beyond that because patients can get nauseous and all kinds of stuff. Yeah. Oh yeah, like high while you're like breathing it, you sure can get high. People around the person, they say no, but I get a headache every time I gave a patient nitrous oxide. I got a headache. So I swear I got something. But secondhand, I never felt like high, but I felt headachy. But yeah, I know. With nitrous? Well, usually once you start and you titrate it up like 5%. So usually when someone's around maybe 20%, they start feeling warm and tingly, but it's very different on everybody. Like some people don't feel anything till they're above 50%. And then some people feel like a little bit around 10. So it really does depend. And then the minute you put the person on 100% oxygen, you got to do that. And the only thing that's bad is they might walk away with a headache, but it has to do with becoming hypoxic for a short period of time, and that can cause a headache. So it's not like, they're breathing, they're getting oxygen, but it's that change in the blood level of it.
So we're into each other, right?
Oh yeah. Oh yeah. You all get to have fun. It's like the fun day. Yeah. Yes. In general, for pregnancy, really the answer is no. It's a weird area because they do, in some places and in the past, they've given women nitrous when they're in labor, but that's usually like the baby's on the way out. So they're not so worried, about development and things like that. So in general, nitrous is contraindicated for pregnancy, but it is a bit of, there are some things that happen with nitrous, but for your purposes, you can be like, yeah, no, there should be a scavenger to make sure there's no nitrous leaks. If you're in an office that does nitrous and you plan on family planning, you should be aware of that and make sure that you're not getting exposed to it. So, am I done? Do I have to stop? One more minute. Okay, so these are just pay attention to this slide for your mechanism of action. Just think of your, for analgesic and sedation, it's the mu receptors. And then for benzos, for CNS sedation, it's the GABA receptors. And this is just a little bit of, you can see the percentages and some of the things that you might feel at the different percentages of nitrous. I know it kind of jumped around a little bit there. Don't worry about this slide so much. Nitrous is obviously absorbed through the lungs. It's exhaled. It can come out the skin a little bit. You will, the minute you stop breathing it, the effects go away once you start getting oxygen in there. And then those are some big take home points. I think that's the last slide. Yes. Okay. Oh my gosh, we did it. Okay, that's it for oral medicine. You guys survived it once we get the exams done. You did it. I know. It's so crazy. We'll have a good review on week 15. Maybe we'll see. We'll see.
This is when I took nitrous. I was.
Were you
They,
laughing?
they gave me only 10, and then I was laughing so hard.
Here, let me
See?
hold on, let me check. Oh my God.